This comment is hands down one of my all-time greatest hits. It comes so frequently, it's kind of scary. And my favorite one that I got back from a surgeon, person had total shoulder replacement. There's a lot of work that goes into that surgery under anesthesia, but then like on the back end of that surgery when they're doing physical therapy, there's a lot of work. So there's like the trauma pieces of the surgery, and then there's a lot of work that goes in behind it. And someone told me once that there's no way that somebody with a total shoulder would ever have their shoulder above 120 degrees again. And I was like, wait, you just fixed the joint. Why can't we get it above 120 degrees? I bet we can. And so I did it. And I also told that person, in the process of doing all of this, you're going to get headaches. You're going to get neck pain. Totally normal. And I can fix it if you tell me it's happening. This was the first total shoulder I had ever seen from this particular surgeon, but he was told by his colleague, oh, send him to this girl. She gets amazing range of motion back in these clients. And he tells the patient, your physical therapist doesn't know what the hell she's talking about. I'm going to show you an anatomical picture of the shoulder and why I'm not wrong about shoulder, neck pain, and headaches all being linked. So first off, this is the shoulder joint, right? So like this is the head of the humerus and this is the glenoid fossa, which is part of the shoulder blade, which also connects to the bicep right here at the coracoid process of the short tendon of the bicep attaches here. And then this is the clavicle, and this is the acromioclavicular or AC joint. When this joint doesn't move appropriately, this joint over here, this sternocleido joint, or where the sternum and the clavicle meet, sternum clavicle, that joint doesn't move correctly. So recall that I said attaches to the shoulder blade. Here's the shoulder blade. This is the upper trap and middle trap, lower trap, right? So there's trigger points even down here in the lower trap, which helps hold your shoulder blade in place, by the way, that cause headaches all the way up here at the base of the skull. Not to mention the fact that this lower trap is holding the shoulder blade onto the body and attaches to the spine. So does the middle trap, so does the upper trap, and you'll notice it attaches directly to the neck and to the base of the skull. So reason number one. Underneath the upper trap, you have the levator scapulae muscle, which attaches to the corner of the scapula and up to the base of the skull. This picture of the trigger points in the levator scap, as you can see, cause pain up into the neck and pain down the shoulder blade and across the back of the shoulder blade. This is the rhomboid. It also, you'll notice, attaches to the spine and to the shoulder blade. And again, just holds the shoulder onto the body. No big deal, though. I'm sure it has nothing to do with your neck and back pain and your shoulder pain. One of the problems is that as a physical therapist, it's my job to know how your body works together to move correctly. And one of the problems of a surgeon is a lot of times, even after they've become like an orthopedic surgeon, they end up specializing in like one joint and they're really good at that one joint, and they might do others on occasion, but like really this is their area of focus and they don't look at anything outside of that joint. So like the surgeon did a killer job at cutting off the head of the humerus and cutting off the glenoid fossa and even removing some of the acromial clavicular bone spur that had formed and replacing the parts that needed replaced and just getting rid of the stuff that didn't need to be there. But he forgot about the musculature. On top of that, when they do all that, they basically lift the pec off the rib cage. The ribs aren't like your anterior ribs and your posterior ribs. Nope, it's a C-shaped bone that's connected from front to back, from the sternum to your spine. When you move those, because you lift a muscle that's attached to them out of the way, you move the whole thing. So you displace the whole thing. So back pain is pretty common after a shoulder surgery. So is neck pain and so is headaches. And that's not to knock orthosurge because we need them. But it's also to say that, yeah, sometimes when they talk to their patients about me, I want to be like, hey, buddy, can we revisit that for a second? Can we go back and look at the anatomy? Review it. And then apologize. And also tell the patient, hey, you know what? Your PT was right. My favorite case ever, though, was that I had worked with an orthosurge from the time well before I graduated with my PT degree. And my last name is pretty recognizable, so all the guys in town know me. And then when he went to have his knee replaced, he started interviewing PTs around town, and he had had a shoulder injury a couple years prior, and he had a different PT do his shoulder because he had heard that shoulder rehab with me was a bit on the extreme side because I don't let my shoulder patients fail. It's not an option. So when he came to interview me, he's like, you know, what are the things that I need to be aware of? And I said, well, first of all, do you remember how many times you've told a patient, especially when working with me, that there was going to come a point where they had to work through their pain? And he's like, yeah, I vaguely remember. He's like, just joking. I remember all the times that I've said that to a patient working with you. And I was like, okay, fantastic. Keep that in mind. And he's like, okay, I will do that. And I said, second, there's going to be a time point because you're still relying on your other leg and you've been relying on it for a while that your whole back is going to become off kilter. So I just want to be upfront. Do you have any low back issues now, particularly with like your SI joint or your hip? And he's like, funny you asked that. And you're the only PT that's asked it. Yes, I do. Why? And I was like, well, you're probably going to have a sciatica flare up. Just tell me when it happens. We'll fix it. He booked his day one post-op patient visit that day in my office. He didn't even walk out of the office. He just walked up to the front desk and booked his appointment. And it's interesting because the whole body is connected. And they forget that. And it's not because they're not good at their jobs. It's because we've become a ton of specialties. His entire specialty was the knee. He did knee replacements and ACL reconstructions. That was what he did for a living. I never saw another surgery out of that guy. I have another orthosurgeon guy that I refer to that only does total shoulders. If somebody's having a total shoulder replacement, I want them to see that guy because that's what he does all day. If somebody is having a foot and ankle issue, I've got a guy for that. If somebody's having a wrist issue, I've got a guy for that. So they know their area really well, but sometimes they forget about the things that attach to it. It's the same reason someone will get a diagnosis of carpal tunnel and they come to me and I'm like, it's not carpal tunnel, let's not do the surgery, because there are some insurance companies that require them to do so many PT visits before they approve surgery. And I'm like, let's not do the surgery. Let's do a little bit of PT, work out the kinks at the elbow and at thoracic outlet, and see if the hand doesn't get better. Now, the hand surgeon only guys don't really like it when I say that because they only, really make money when they're doing hand surgery. But the guys that see the whole patient and they treat like shoulder, elbow, and wrist, they get what I'm saying and they fully appreciate it. But just like sometimes plantar fasciitis isn't plantar fasciitis because it's coming from the neck, you have to remember that the body is one ecosystem.